Okay, hi guys. Can everyone hear me okay? If you can hear me well enough, or there's any lag, just let me know in the comment section. So welcome to today's lecture. So today's topic will be the telencephalon, the ventricles, the meninges, and the blood supply of the CNS. So without any delays, let's get on with it. So my name is Stephen, and I'm a fifth year medical student, and I'm from the UK, and that is my personal Hotmail account for anyone who has any issues with this lecture, or they'd like it, or perhaps they want to message me privately or whatever. That's my email. Right, so so today's lecture, I will try and work through in A to Z fashion. So I will obviously give you an overview of the telencephalon, and then we will kind of break it down into the subcortical structures as well. So we'll be talking about the hippocampus, the basal ganglia, the tracts alongside the internal capsule, and then we will try and talk about the ventricles, the meninges, and then finish it off with the blood supply, the CNS. So, so just before we actually start the actual material, what are our learning outcomes today? So our learning outcomes will be obviously to leave with appropriate knowledge, understand the relevance of the anatomy, rather than just studying it to pass the exam. You should try and understand it in the context of clinical practice, and try and relate as much as we can. And then obviously the clinical correlation. So I like to add a few of these correlations just so that you can kind of understand the actual implications of what happens when things go wrong. And also, it's just interesting to know where things are going wrong as well. So I've added a few pathologies alongside all of the theory, and then as we go along, if there are some tips I can give regarding the dissection exam and the final exam, I will say them obviously. So before we actually get to the actual the meaty stuff, what would I advise you to study from and what? So in terms of neuroanatomy, I would probably advise everyone to read, preferably from university literature, so the lectures, their own books, so such as this white book in the on the slide here. So I would probably use that, and I would use that as my main source of information to actually learn. And then possibly you could supplement that with possibly Netter Atlas or Sabota or any other atlas, but I would use this as the basic foundation source. And I've written draw and draw and draw and draw. That's because I think that the more you draw, the more things can be visualized easier, and the more things make sense as well. So I think from that point of view, drawing will also give you a bit more confidence when you have to describe and answer questions, and also it just gives you kind of a 3D perspective as well, and which is quite useful in exams when perhaps you don't quite understand what you've been asked, but If you can visualize it into an image, maybe you might be able to get yourself out of a tricky situation then. And then final point is use the atlases to consolidate. And what I did, which was very helpful when I was doing my anatomy exams, was to describe the image, perhaps before you go to sleep, or in the morning or whenever, after you've read the topic. So let's say you've read the spinal cord, and all of the plexuses, etc. So if you've read the whole section, you open up your atlas and you just try and describe it to the best of your knowledge, and I think that also promotes quite a lot of confidence in public speaking and also just generally speaking about the topic. So I think those are very, very good things for practicing and revising. And then dissection, you have the conventional flashcards, atlases, but I think my one piece of plug-in, possibly you could say, would be Ackland's Video Atlas, because I think that it's a really, really good tool, purely because he makes any cadaveric dissection and identification of structures very, very easy. So if you would like more help, I would probably suggest using Ackland's, and also it helps you revise the entire topic as well. So that's my study guide and my advice. As for this lecture, I've put a spotlight in the corner. So these are the questions from your syllabus that will need to be answered. And I'd like to think that by the end of my lecture today, you should be able to speak about these, at least in basic terms. And yeah, that should stand you in good stead alongside your own self-study. So as you can see, these questions are quite general. There's a lot to talk about with these, and so I think let's start. So what is the telencephalon? So embryologically, the telencephalon is a rostral derivative of the embryological prosencephalon. So I'm not going to stand into an embryology lesson, but we know that the brain is made up of three embryological derivatives, and the most rostral of those, so the most superior, is the prosencephalon, and the actual telencephalon, when we talk about, for example, any other organ like the gut or the stomach, we talk about the epithelium. And the brain doesn't quite have epithelium, instead it has cortex, and this cortex is composed of multiple layers of cells and structural support systems. So the telencephalon is made up of the paleocortex, the archicortex, and the neocortex. So the paleocortex is made up of the rhinencephalon, and it includes the olfactory bulb and the region. The archicortex is composed of the Ammons horn, and it basically makes the medial wall of the hemispheres, whereas the neocortex, which covers the majority of the cerebral cortex in terms of composition, that makes up the vast majority of it, and its function, or its role, you could say, in these layers is sensory perception, cognition, motor command, spatial reasoning, and language. So the neocortex, in terms of importance, is very, very, very important because it obviously controls a lot of daily tasks and daily functions that we perform as humans. Hence why when there are certain structural pathologies or there's damage, quite often it's the neocortex which is the most damaged. Like I've said, so it's an embryological derivative of the prosencephalon. But just before that, how is it different to, let's say, the diencephalon or the mesencephalon? So I won't go into those topics too much because I think they've been discussed in previous lectures before. But how this, how the telencephalon is different from the diencephalon, for example, is that the grey matter is actually externally located, so it's cortical. So what we mean to say is it's essentially forming the outside coat, whereas the actual internal internal layer, you could say, of the telencephalon is where the white matter tracts are, and also the nuclei. So that is the kind of background of the telencephalon. Just a few starting points and a small overview. And in terms of describing physically what we would see in terms of the telencephalon, so each hemisphere contains a convex superlateral surface, and it has a flat inferior surface and a vertical medial surface. And now you're all going to see the following slides what I mean by that. We obviously know that the main or the parts that everyone associates telencephalon with are obviously the lobes. And within those lobes you have gyri and sulci. So we know that there are four lobes. It's the frontal, parietal, temporal, and the occipital lobe. So let's get on to where to begin. So let's say you're in dissections. You've been you've been given a brain to describe. Where do you begin? So the way to begin is, I think, to define first these first two terms. So what is a gyrus? So a gyrus is a rounded eminence or a convolution, and we'll get on to what I mean by gyruses in the images that will follow. And then the separate or a different term that we can also use in terms of starting off is sulcus. So a sulcus is a groove or a depression in the cortex or on the outside of the cortex, and we have six different landmarks which are very, very visible and are kind of like our landmark, which are like landmarks to start from and possibly expand on. So when we locate these six different landmarks, then we can kind of become a bit more spatially aware with what we're dealing with and where we are, because I think, as you all know, not every single brain looks like a textbook brain. So once we can identify these sulcuses, we can then navigate ourselves around the brain. So starting, like I mentioned, we've got six sulci. Can anyone see my... Okay, yeah, got my mouse. So, like I said, that we've got six sulci that we should try and identify before we go into what this gyri is or what lobe we're in. So the first one is the lateral sulcus of Sylvius. So this is this small groove here on the lateral aspect of the brain. You'll notice that this is the temporal lobe. So it's sort of dividing the parietal aspect and the frontal aspect with the temporal aspect here. We have the central sulcus, and the central sulcus is dividing the frontal lobe and the parietal lobe from the occipital lobe and also the inferior parietal lobes and the gyri relevant to those lobes. And we also have the calcarine sulcus, which is found near the occipital pole in the occipital lobe. It's better seen inferiorly or from a medial view. And then the next sulcus that we should try and identify is the parieto-occipital sulcus. So we know that this is the parietal lobe, this is the boundary for the occipital lobe, and then the sulcus is the dividing factor. Yeah, and then obviously we have the superior frontal sulcus here, because we've got 3 parts, or 2 parts really, of the frontal lobe. We've got the superior frontal lobe, we've got the middle frontal lobe, which is kind of hard to distinguish sometimes, and then the inferior frontal lobe. So once again, this is a caudal view, and a caudal sectioned view of the brain. And as I said, the calcarine sulcus is best visualized from an inferior view. So if you just follow my mouse, it is right here. This sulcus is part of the occipital lobe, and it is the calcarine sulcus. Of course, we have other sulcuses which are important, but they're not exactly the most visible. And those are collateral sulcuses, which essentially just divide the diencephalon from the subcortical parts of the telencephalon. Once again, this is a another view of the brain from a sagittal section, and this image, I think, quite nicely demonstrates what these sulci actually distinguish. So we can see here that this is obviously our medial aspect of the frontal lobe here, and this is our parietal lobe here, and this central sulcus, it's almost like a very, very, very clear border which is distinguishing the frontal lobe from the parietal lobe. You cannot see the lateral sulcus of Sylvius, obviously. So this is the overview of the sulci and the gyruses. We could go into each separate gyrus, but I think it would be a time-consuming task right now, and we're a bit pressed for time with what we have to cover. But my tips for learning gyri are breaking it down into lobe by lobe. So for example, like we mentioned before, the frontal has a superior part, has a middle part, and then has an inferior part, and basically just active recall, just continuously seeing images of the frontal lobe, and then just working your way from each separate lobe, and then possibly after you've tested yourself a few times, then you bring it all together and then try and identify all of the gyri as a whole rather than individually. So I think the whole context of knowing what gyrus is which and where the gyrus is, it's all relevant because we have cortical fields, and these are, or they were mapped by Brodmann, and essentially it is a map for medical doctors and also other healthcare professionals to map which area is responsible for which function. So the most important areas that you need to learn are the areas that I've included in this table. So, for example, we know that the areas 3, 2, and 1, which are located on the postcentral gyrus. So, postcentral gyrus, what does that mean? So, postcentral, obviously posterior to the central sulcus. So, we know that this area here, right behind the central sulcus, is the primary somatosensory cortex. So we know that all of the upper motor neurons will be, or upper motor neurons will be starting from that part of the motor cortex, and then they'll obviously go to the responsible nuclei, and then their journey is onwards from there to lower motor neurons, etc., etc. And for each of these areas, we have a corresponding function. So we know that the postcentral gyrus is obviously primary somatosensory that we just mentioned, and we know that the gyrus, which is precentral, which is before the central sulcus, is the primary motor cortex, which is in the frontal lobe. And then I could go on and on and on here, but I think we get the idea of what Brodmann's areas relate to and the corresponding functions. So in general, usually you can basically use this as an easy way of remembering things. So usually the occipital lobe is responsible for the visual side of things, so it's the visual cortex. The temporal aspect is used for sound, so listening. Precentral here is the motor cortex, and the postcentral is the somatosensory. And yeah, that is cortical fields. How do cortical fields relate to clinical practice? So, for example, if we have a hemorrhage, if we know that the blood is compressing one part of the brain, we can map which area and what function could be affected, or on the other side of things, we know that if a patient cannot perform a certain function, we know that that part of the brain is affected the most. And I think the hardest part of everything clinically with this whole cortical field model is understanding that before all of that, when we break everything down into a cellular level, it's actually the motor neurons that will be affected more significantly. And once these motor neurons are affected by inflammation, injury, bleeding, whatever it may be, that's when our functions are restored to nil, basically. So this man here on our left is obviously Professor Stephen Hawking. He suffers from motor neuron disease, and the condition that he suffers from is called systemic muscular atrophy or spinal muscular atrophy, and it's a form of amyotrophic lateral sclerosis, and it's usually the entire motor neuron system that is affected. And we know, or we know from all of our other previous knowledge, that the upper motor neurons will be going, or they obviously terminate in the horns as lower motor neurons, but we also know that they start off in the cortexes where before they go to the responding nuclei that they're responsible for. So once that upper motor neuron is damaged and affected, your transmission will not exist, obviously, and unfortunately, you'll tend to get symptoms of motor neuron disease, which almost impact nearly 100% of your body. So that is the clinical correlation here with motor neurons and the cerebral cortex. So now that we've talked about the telencephalon as an overview and of the cerebrum, I think we can talk about the subcortical structures. By the way, does anyone have any questions? If you have any questions, just fire away on the chat. I'm just looking at it right now. If anyone has any questions. Okay, none so far. So back to what I was saying. So the hippocampus is subcortical, and what is it made up of? It's made up of the dentate gyrus. It's made up of the proper hippocampus, also known as Hammond's horn, and subicular complexes. So it's made up of the subiculum, presubiculum, and the parasubiculum. And the final thing it's made up of is the entorhinal cortex, which is area 28 in terms of cortical fields. And what is the function of the hippocampal formation, or the hippocampus? Essentially, it is an integrative organ with connections to the endocrine and visceral systems, as well as alongside its other functions, which are primarily memory formation, memory retention, and also behavioral evolution, and also emotional evolution as well. So here is a superior dissection, or a caudal dissection of the brain. So we can see that this is our hippocampus here. This is our structure. So we know that the let's go back to it. So we know that the dentate gyrus is one of the components of it. So the dentate gyrus is right here. Then the next thing that it's composed of is the proper hippocampus, or the Hammond's horn. If you can visualize it here. So I think in the following images you'll see that a bit more clearly. You can't see it very clearly here. And then obviously we have the thalamus here, and these horns and the fornixes are all lateral to the thalamus, which is very central. Yeah, this is a better image, I think. So you've got your mammillary bodies here, and you've got your amygdala here. So the amygdala is primarily responsible for emotions, whereas the mammillary bodies play a very, very important part in memory formation. And this is the entire hippocampus here. We can see that this is the fimbriae, which is kind of fenestrations on the surface. This is the crura, This is the commissure of the fornix, and this is the main body of the fornix. And then once again, in terms of coronal view, just so we can relate to it from a different view, this is our dentate gyrus, which, like we said, was one of the constituents of it. This is the fimbriae, which we just mentioned here. So if you can kind of relate to it, where this is the optic tract. So it's hard to describe it to you, but the thalamus will be somewhere here, and this is all lateral. So our dentate gyrus here, and the optic tract is obviously in the the anterior fossa. So that's roughly where our position is in the context of the optic tract, which is superior to the hippocampus. And another really important physiological function and anatomical circuit which is involved with the subcortical physiology in the anatomy is the Papez circuit. So it is interconnecting between many different structures in the limbic system. So some of these are the hippocampus, the mammillary body, the cingulate gyrus, thalamic nuclei as well, and it's basically communicating with them or with all of these structures via fibers and also neurons, and it is important for our long-term memory. So this is the Papez circuit. Okay, so basal ganglia. What is the basal ganglia? So basal ganglia is responsible for the control of voluntary motor movements, procedural and habit learning, or just general learning, you can say as well, cognition and eye movement and emotion. It is strongly connected with the cerebral cortex, the thalamus, and the brainstem. And in terms of its cellular structure, it's made up of grey matter complexes which are embedded deep within the internal white matter, and it's made up of 5 different things. It's made up of the striatum, the pallidum, the lentiform nucleus, the amygdaloid body, and the claustrum. And we can break some of these things down into 2 separate components of them. So striatum is made up of the putamen and the cardiac nucleus, whereas the pallidum is made up of the globus pallidus, both the external and the internal, and the lentiform nucleus is made up of the globus pallidus and the putamen. So here is, once again, this is our internal capsule here. In terms of the basal ganglia, so basal ganglia is this region here. You can see that you have the putamen here and the globus pallidus, which forms the pallidum, or also the lentiform nucleus. We can see the internal capsule, which is anterior to it, which is also responsible for many similar functions. We know that, or like I mentioned before, that it's all interconnected with the thalamus, and that's because of its close proximity. This is our, this is the tail of our cardiac nucleus right here. Yes, so this is the horizontal section. The basal forebrain. So the basal forebrain is in the anterior cranial fossa. It is carrying out similar functions to the basal ganglia, but more importantly, it's responsible for cognition and wakefulness alongside REM sleep. So if you don't know what REM sleep is, it's rapid eye movement sleep. So yeah, it's responsible for those two things. And it's also known that it's a major hub in the brain where a lot of the acetylcholine is produced and dispersed along in the brain. So just right here in the anterior fossa here is the basal forebrain, and anatomically, where is it located? So it's a ventromedially located structure on the cortex, the telencephalon. This is our thalamus here, so it's obviously anterior to that, and more medial to the basal ganglia, you could say. And it's an extension from the olfactory tubercle to the hypothalamus. So I haven't really mentioned it in these slides, but the olfactory bulb is a very important part of the telencephalon, but it's not really mentioned too much in your books. But the olfactory bulb would usually be just inferior to it here. So this is what I mean when I say it's an extension from the olfactory tubercle to the hypothalamus. And it includes the anterior perforated substance, the medial septal area, and the substantia innominata. And this medial septal area here is made up of a pre-commissural part and a supracommissural part, whereas the substantia innominata is made up of the basal nucleus of Maynard, which is the main producer of acetylcholine in the brain. That's the basal forebrain. So just to recap what we've been through up until this point here, we're talking about Y-matter tracts from now. But just before, so we've obviously talked about the telencephalon. So we've talked about the how to identify lobes, and we identify lobes by finding their sulci, which are almost border-like landmarks which help us differentiate between certain lobes. And then when we can identify the sulci, we can then start beginning to navigate our way around the lobe. And once we can navigate our way around the lobe, then we can identify certain gyri. Gyri are convolutions in the lobe, and the cortex, or or you can even say the cortex, or the cerebrum, or the telencephalon. All these three terms. Why are they important? Well, they're important because each gyrus is responsible for a function. So, for example, we know that the precentral gyrus is responsible for motor function. We know that the postcentral gyrus is responsible for somatosensory function. And then, like I said, you don't need to know the exact, well, you do, but as you get older, you don't need to know the exact areas for everything, but you need to know that the occipital lobe in general is for the visual cortex, and the temporal lobe is for the auditory system. And then after we discussed the telencephalon, then we started to break down the subcortical structures. So we mentioned the hippocampus, which is an integral part in the our brain in forming memories and just forming synaptic retention for us to create those memories. And then we talked about the basal ganglia, which has got many other functions such as cognition, and it also plays a part in voluntary movements. And now we're on to white matter tracts. So obviously you've got projection fibers, you have got association fibers, and then you've obviously got commissural fibers. Why do we have them? Well, we need to know, and we need to remember that throughout all of these anatomical structures, we have got neurons, and we've got fibers, and we've got lots of tracts which are communicating from certain nuclei, and they're going all the way up to the cortexes. And those are specific functions. And we also have connections from, for example, different hemispheres. So, for example, the left cerebral hemisphere will be connected to the right cerebral hemisphere via association fibers, and we have long fibers, for example, superior longitudinal fasciculus, or SLF. It's similar to the MLF. And then we also have short fibers, or known as U or arcuate fibers, which are within the cingulum. And then the commissural fibers are almost, or they are interhemispheric connections. So from, or within one lobe, you can, or we can have a transfer of information from the frontal lobe to the parietal lobe to the occipital lobe, and those are via the corpus callosum, the commissure of the fornix, and others. And basically, the corpus callosum is the largest set of commissural fibers in the brain. And it's a pathway of crucial importance to speech and language functions, and it's the major connection between the hemispheres as well. And alongside all of these, like I mentioned, we have anterior and posterior commissure fibers, and the anterior commissure connects the olfactory bulb, the amygdaloid nuclei, and the medial and inferior temporal lobes, whereas the posterior, you can see it, the posterior commissure fibers connect areas in the occipital lobe, which are primarily concerned with pupillary response and eye movement control. So I kind of mentioned it very briefly. I don't really think I mentioned much of it, but I mentioned that the anterior, or the internal capsule, is anterior to the basal ganglia, and so the easiest way of thinking about what the internal capsule functions as is, it is like a bus stop. So it's carrying information, signals, which are kind of like the passengers from or past the basal ganglia, both to and from the cortex. So this can be in the form of motor or sensory signals, or it could also be motor or sensory cortexes. So I think in the following image, I'll actually describe the composition of the internal capsule. But you'll see in this image here that the corticospinal tract is making up quite a large proportion of the internal capsule, and that's because this tract is very corticospinal based or very motor based, and it's usually the transfer point where the upper motor neurons will then join their secondary neurons, which will be the lower motor neurons, and then the lower motor neurons will obviously take the information to the ventral horns of the roots, etc., and then we'll be able to process the information in the form of a motor motion. And here is the caudate nucleus. Caudate nucleus is right here. You have the lentiform nucleus here, which is the basal ganglia. Can anyone remember what the lentiform nucleus was, or what the lentiform nucleus is made up of? So the lentiform nucleus is made up of the globus pallidus and the putamen, whereas whereas the caudate nucleus alongside the putamen forms the striatum. So this is a more broken down image for you to kind of process. So once again, we're at the internal capsule here. This is the insula. This is the extreme, or this is the extreme capsule. 7 is the claustrum, and then 6 is the external capsule, which is obviously differentiating, or which is distinguishing the differences between the internal capsule and the outside of the cortex. And then here, number 5 is the putamen, and then we've got our globus pallidus here. So this is our globus pallidus externus here, and this is our globus pallidus internus. And both of these form a very important pathway for diseases such as Parkinson's, because each externus and internus have different feedback pathways with how they communicate to the thalamus. And then here is our caudate nucleus, and then this is the main internal capsule. So in terms of these tracts, you've got you've got your cortical tracts here. So you've got corticospinal, corticonuclear here. I can see very clearly you've got your posterior thalamic, you've got your anterior thalamic, and then this is a thalamus. This is the genu. Anterior limb is here, which is made up of the anterior thalamic and the FT. Right. So going back to the internal capsule here. So this is what it would look like in a horizontal section through the cerebrum. So here is the internal capsule, this kind of bracket-like shaped um, structure here. So you've got the anterior limb here, which is composed of FP and ATP tracts. Then you've got the genu, and then you've got the posterior limb, which will be made up of a lot of the corticospinal tracts and also the posterior thalamic and the anterior thalamic tracts. And then you've got your external capsule here. Then you've got the claustrum, which is this bit here. And then you've got the extreme capsule, which is another layer lateral. And then you've got the insula, which is right here. So that is the internal capsule. Like I mentioned, how is this all relevant? So the clinical correlation with the internal capsule, the basal ganglia, and most subcortical structures are that if there's any dysfunction between the transmission from the cortex and all the systems down below, we can possibly get Parkinson's disease. And a lot of these diseases, such as Parkinson's, also rely on a hormonal or neurotransmitter levels to be at normal. So, for example, Parkinson's is a depletion of dopamine, dopaminergic dopaminergic neurons of the substantia nigra, and if there's a depletion of these dopamine neurons, then we can start having symptoms of Parkinson's, which could be a tremor, it could be rigidity, and then it could be all kinds of ataxia, which is not being able to balance and coordinate your movements, and also posture. You can see that you tend to have abnormal posture, and it's caused by decreased dopamine in the substantia nigra and also the basal ganglia. So if there are no questions, if there's no questions, maybe I can carry on with the ventricles. So we've got 3 different ventricles in the brain. So we have the third ventricle, and we have the fourth ventricle, and also the lateral ventricle. And the third and fourth ventricles secrete the CSF, which is cerebrospinal fluid, with the help of their choroid plexuses. And the cell that's responsible for creating and secreting this CSF are ependymal cells, which line the choroid plexus. I think in the following slides you'll see an image which will describe what I'm trying to say. But in terms of the third ventricle anatomically related, anterior superiorly on each side it's communicating with the lateral ventricle via the Monro foramen, and anteriorly it is anteriorly by the column of the fornix and posteriorly by the tubercle of the thalamus. So once again, we're subcortical. The lateral ventricles, which are in communication with the third ventricle, are two irregular cavities situated in each cerebral hemisphere. And like I said, they communicate to the third ventricle via the foramen of Monro. And we have a fourth ventricle, which is in the hindbrain, which is the most inferiorly, or which is the most inferior of the embryological structures of the brain. And it is a tent-shaped space which is situated between the pons and the upper part of the medulla oblongata in front, and the cerebellum is behind. It is dorsal to the pons and upper part of the medulla, and ventral to the cerebellum. And the cavity of the fourth ventricle communicates inferiorly with the central canal and superiorly with the cerebral aqueduct via the cerebral aqueduct, or the aqueduct of Sylvius, which is what it's also known as. So here, I'm not sure you can quite see the third ventricle very clearly, but the third ventricle is not not very easily visible here, but it's the small of the cerebral subcortical ventricle. So you've got the third ventricle here, and the choroid plexuses are secreting the CSF, which are communicating with the fourth ventricle via the foramen of Monro, and then they are also obviously going through the cerebral aqueduct, or which is the main aqueduct of transferring all the CSF produced down far away from the brain. But before it goes into the spinal cord, it must pass through the fourth ventricle, which is, like we said, a tent-shaped fossa. Cerebellum is posterior, which is here. You've got your pons and your medulla oblongata, which is anterior to it. So this here is the Sylvius aqueduct. That is what connects the fourth ventricle to the cerebral aqueduct here. In terms of how much CSF is produced by the body every day, so I think daily we produce 0.35 mils per minute, which equates to roughly 500 mils of CSF every single day as adults, but in younger adults or children, the production of CSF is roughly 150 mils, and only 25% of the CSF volume lies within the ventricles. So either in the third, the lateral, fourth, whereas the rest is in the spinal cord, which is obviously composed of its own different layers. But it's mainly the subarachnoid space, which is where the CSF is or can be found. And another important point about the CSF is that obviously it is it's a clear fluid. It's not a fluid that has been pumped out of blood, like plasma, for example. It's its own independent fluid, which is created by ependymal cells in the choroid plexus. And it has, if for example, there is too much CSF, which is surrounding the brain and the spinal cord, we can possibly have some spinal dysfunction and autonomic dysfunction or motor dysfunction due to too much CSF and compression as well. So, like I mentioned, so this is the choroid plexus of the third ventricle. So this plexus is creating all of the CSF via its ependymal cells, and they are then communicating with the the lateral ventricle here via the foramen of Monro, which isn't labeled, but this is the foramen of Monro. And then they're passing through the cerebral aqueduct of Sylvius here into the fourth ventricle. And then after they've entered this tent-shaped fossa, which is the fourth ventricle, most of the CSF will rest or reside in the subarachnoid space in the spinal canal. And how does it get into the subarachnoid space? Well, it gets into the subarachnoid space via the the lateral aperture or the foramen of Luschka, which is in this tent-shaped fossa, which is the fourth ventricle. So via this small orifice opening, the CSF can rest and also provide structural safety and shape to the entire spinal cord and the brain. Another coronal image once again. So this is the lateral ventricle. I'm not sure you can see the foramen of Monro very clearly, but foramen of Monro will be somewhere here. This is our third ventricle. It's in communication, and we unfortunately cannot see the cerebral aqueduct, but we know that it would be caudal to this. So that was the ventricles. Why have I mentioned this case? So this is a case of hydrocephalus. So hydrocephalus means there is a excess or accumulation of CSF in the ventricles, or in either the third or the lateral ventricle. It's quite common in children because of their fontanelle, the anterior fontanelle not fusing, which causes there to be some kind of communication, which causes a bulging out of excess CSF. So here you can't even make out the third ventricle or the lateral ventricle because there's just so much CSF here, and the CSF is obviously compressing the cortex and also other structures down below, maybe even the cerebellum, and it's quite a dangerous condition because it can increase your eye pressure, so you can sometimes you can go blind temporarily and even permanently if your intracranial pressure is quite high because of lots of CSF, and it can cause herniation, so possibly the cerebellum could easily leave the skull, and it could actually end up being trapped possibly in the foramen magnum, and that is quite catastrophic. So this is what happens when you've got excess CSF being produced, and this excess CSF is either due to some structural abnormality, such as a tumor possibly, or all kinds of genetic malformations which prevent communication between different structures. It can also be due to hemorrhage, which usually affects the subarachnoid villi, so you'll have less CSF reabsorption, and it can cause a lot of problems. So, are there any questions from anyone? Yeah, I can answer them right now before we start the meninges. So if you have any questions, just pop them in the chat. Okay, I think there are no questions. So the next topic is the meninges. So the meninges, or the leptomeninges, you might read in some books. Some books say meninges, some say leptomeninges. What is the meninges? So the meninges is essentially the pia mater. So we know that the three maters in the brain that we talk about most are the dura, the pia. The dura mater, the arachnoid, and then the pia mater. So the pia is the most superficial surface of the brain, and if there is any inflammation of the pia mater, it can cause meningitis, because the blood vessels which run in the subarachnoid space, which are connecting the arachnoid, or the arachnoid and the pia, if there's any pathogen, for example, which is leaving this blood, or it's somehow communicating with the pia, it can cause the inflammation, and we get meningitis, which you can see in this enhanced CT image. This is a pia mater. I don't know if you can quite clearly make it out. It's a very superficial surface, and this is a cardinal sign of meningitis if you're looking at it radiographically. Don't want to get into too much detail, but another symptom you can possibly have is these petechial rashes, which can also be a sign of sepsis. And I've got this image here inside a club, and that's because meningitis is quite often spread either by direct contact or by aerosol transmission, and quite often this happens to be in nightclubs, and this is very common for university-going children, because of the nature of the first few weeks of university when you've got Freshers' Week, etc. And you can cause meningitis, which is the inflammation of this pia mater here, the most superficial surface of the cerebrum here, of this brain. So the final part of today's lecture is the blood supply of the CNS. So we know that before we start, so we know that the blood supply of CNS, it starts from the internal carotids, or it starts from the common carotid, where the common carotid then branches into the internal and the external. And then we know that the internal carotid will then branch off into smaller branches. And these smaller arteries will then be providing the vascular supply of the different various parts of the brain. So you start off with if you start off with the internal carotid, so the internal carotid, the first branches that it will give off will be the here. I don't know if you can see. Yeah. So the first branches that it will give off will be the anterior inferior cerebellar artery, which is right here. The vertebral artery and the basilar artery are continuations. So the first branch will be the AICA, so the anterior inferior cerebellar artery. The next branch that it will give off as it travels up to the brain will be the pontine arteries, which will be supplying the pons. Then you will be having branches to the superior aspect of the cerebellum, so you have the superior cerebellar artery, and then you can also sometimes get branches here to or collaterals, which are perforating arteries in the posterior medial part of the brain. And yeah, you can sometimes get collaterals, which are here, you can see. And then you get to the one of the three main branches of the circle of Willis here. So you have the posterior cerebral artery. I think in the next slide you'll see the areas that this posterior cerebral artery will be supplying blood to. And then it's communicating with the middle cerebral artery, the MCA, via a posterior communicating artery. And then if there's a posterior, there's a middle, then there has to be an anterior. So there's an anterior cerebral artery which is communicating with the middle through the anterior communicating artery. And the middle cerebral artery is one of the most commonly injured arteries in the brain, just because it's very, very lateral and it is in close proximity to the surface. That's why quite a lot of the time, if there's any accidents, such as road traffic accidents, and if there's any head trauma, the middle cerebral artery is usually the one which is impacted the most. And because it's the middle cerebral artery, we can have all other different branches of this middle cerebral artery. So, for example, you've got branches going to the hypophysis. So you've got the superior, and then you've got the inferior hypophyseal artery. You've also got the hypothalamic artery, and then you have the lenticular striate arteries, which will be supplying the basal ganglia. And for example, if you have a stroke, and if it's a lenticular stroke, it's affecting the basal ganglia, so hence why you tend to have movement disturbances in the form of paresis, which is weakness and drooping. So yeah, this is the lenticular striate arteries. And in the anterior cerebellar artery, you're just giving, or you're getting one branch, which is the distal medial striate artery, or the recurrent artery of Hübner. So yeah, this is the circle of Willis. This is the circle of Willis, and the circle of Willis is composed of three main arteries, once inside the skull, and extracerebrally we have the vertebral artery here, which will be supplying all of the complete musculoskeletal system, or the vertebra, sorry, and then you've got the basilar artery, which just terminates before you get into the skull. So I think in anatomy exams, one of the final assessments after you've answered your questions, I think is they ask if you can identify an X-ray scan or a CT scan, and quite often they like to show an image of an MRA. So this is a magnetic resonance angiograph, and I think it shows the circle of Willis nicely, but it's not very nice in terms of identifying vessels, as you can see here. But I mean, so this is your conventional circle here. This is your this here is your vertebral artery, I think, and then this is your basilar arteries. You can't see the internal carotid very well, which is why this looks very big. So this must be the vertebral artery, and we know that the basilar artery here will give off the posterior inferior cerebellar artery, so the pica. That will be the first branch. Then we know that it will give off the pontine arteries, the pons, and then the superior cerebellar artery before you get to the posterior cerebral artery. And the reason why the context of this circle is so important is because it's a complete collateral supply, as you can see. So if, let's say, one area is blocked or occluded, the blood can still find a way to get to its destination site without impacting the function of the entire brain, which I think is very, very nice. It's a nice evolutionary adaptation. So in the previous slides I mentioned these three main arteries of the circle of Willis and the regions that they supply blood to. So the middle cerebral artery is providing blood supply to the inferior aspect of the frontal lobe, and mainly the latero anterior aspect of the cerebrum, as we can see right here. Obviously, the temporal lobe here, large parts of the frontal lobe, and also the parietal lobe. The anterior cerebral artery is mainly perfusing the medial aspect of the cerebrum, and so it's mainly providing blood supply for the frontal lobe, but also the posterior parts of the parietal lobe just before it bridges into the occipital lobe. And the third artery is the posterior cerebral artery. So the posterior cerebral artery will be mainly supplying the occipital lobe and the inferior margins also of the um, temporal lobe, and the most the most inferior part of the brain. So we've talked about the arterial blood supply of the CNS. So now we will talk about the venous supply, or the dural venous supply. The veins of the CNS, they drain blood from the cerebrum, the cerebellum, the brainstem, and the spinal cord, and after emptying into various sinuses that we can see in these figures here, they will flow into the internal jugular vein via the jugular foramen, and be returned to the heart. So I don't think you can see this image very, very clearly here, but if we're talking, yeah, okay. So veins draining blood from, when venous blood is drained from the brain parenchyma, it can be divided into superficial and deep veins. And the superficial veins primarily drain from the cerebral cortex, whereas the deep veins will obviously they will obviously drain from the deep structures within the hemispheres. These veins don't follow their um, their artery peers, you could say, in the skull, and there's a lot of anatomical variation when it comes to veins. So we can't relate with the arterial supply for, or the arterial system of the CNS for names or possible paths. And another notable feature is that the cerebral veins lack a muscular wall and valves. So obviously there could be backflow. And yeah, so the cerebral veins, when they are emptied into the dural venous sinus situated within the subarachnoid space, the superficial system will then drain into the superior sagittal sinus, which is right here. So the superior sagittal sinus is in the subarachnoid space, whereas the deep system, which is within the cerebral hemisphere, will drain into the transverse. So you've got the transverse sinus here. So will either drain, the deep structures will either drain into the transverse, the straight sinus, or the sigmoid sinus. Like I said, there can be quite a lot of variation between these structures. So you can have the superior petrosal sinus. Sometimes you can, sometimes you can't. But for the purposes of the exam, learn it with all of these sinuses because they can be present. And this, you've got the great cerebral vein here of Galen, which is mainly draining the really cerebral or the intracerebral hemispheres before it then forms a confluence of the superior sagittal sinus, the straight sinus, and then eventually the internal jugular vein, which will then pass through the jugular foramen, and then back to the heart. So this is the venous drainage supply system of the CNS, and the clinical correlation of this whole blood supply system is that depending on whichever CT here we can see. So, for example, you can undergo a hemorrhage. You can have a intracerebral hemorrhage, or you can have a subarachnoid hemorrhage. So intracerebral hemorrhages tend to affect the branches of the circle of Willis more, whereas a subarachnoid hemorrhage tends to be just below the level of the circle of Willis. So in these images here, you can see this is a huge intracerebral hemorrhage. Once again, this is the same patient. It's a huge intracerebral hemorrhage. We could probably take a guess, based on just this entire region, that it could quite be one of the lenticular striate vessels, which we know are a branch of the middle cerebral artery. And for example, if it was in or just below the level of the circle of Willis, so let's say it was the posterior cerebral artery, it could be subarachnoid hemorrhage. So I mean, you can't really see it very, very clearly. I'm certainly no expert, and I find this difficult to visualize as much as you, but there is a small sign of focal hemorrhage here, which is highly indicative of a subarachnoid hemorrhage. And then in this far image here, this is a hematoma. So you have hemorrhage, which is active bleeding. When you have a huge collection of blood, it's known as a hematoma, or a bruise. It's known as a hematoma, and this is a huge collection here in the epidural space. So that's why it is a epidural hematoma, purely because it's above the dura, so it's epidural. And once again, it's a very, very serious situation. You can see even from this X-ray and CT's images, the swelling is quite profuse. So this is the whole clinical correlation with blood supply of the circle of Willis. I haven't mentioned another thing, which is strokes. I briefly touched upon it in the collateral anastomoses of the circle of Willis, but in stroke patients, sometimes if there's an occlusion in one branch, we have a good collateral supply, which means that other arteries can supply one area potentially. However, that all depends on occlusion, but there is a collateral system which does prevent areas becoming ischemic. And with that, kind of rounding things up now. So these questions should now be answerable. You should have a basic grasp, I think, by the end of this lecture now about what these questions entail and what you could possibly say about them. I mean, in terms of final thoughts, if anyone has any questions, if you could just let me know in the chat, I'll just check it now. Okay, so yeah, if anyone has any questions, just feel free to use the chat, and I'll try and answer them now. Or, like I mentioned earlier in the presentation, you can email me, or you can message me if you're connected to me on social media. But my final thoughts on this topic are, in general, keep it quite simple, or keep it simple, stupid, and try and break it down into the most basic foundations before you start adding more complex information and facts. Always break it down. I think remaining composed is just as important as having the actual knowledge, because if you can't stay calm and relaxed, your brain will be very, very frazzled. And especially for neuroanatomy, I think this is the question that most of us stress about. We've all had nightmares. I had nightmares, just because it seems very, very difficult when we study it, how everything interlinks and how it all makes sense. But just back your knowledge, just remain calm, and just practice and practice and revise as much as you can, to the best ability you can. Hopefully it will pay off. And yeah, don't just sit in the library at home right now and open your book and just stare at it, because unfortunately you will have to actively revise neuroanatomy for it to make sense. And yeah, I mean, in terms of my final thoughts for this exam, you can either you can kind of use all of your motivation and hard work and end up like Usain Bolt in this image. Or, for example, if you don't, if you're not a Usain Bolt, if you maintain your composure, you can do Masaryk in this left image here, and still get it done. So yeah, those are my final thoughts. These are the learning outcomes. Once again, if anyone has any more questions regarding this topic, and if they would also like to ask me more questions about their section and final exams, yeah, please feel free to let me know. And if you could also all fill out the feedback form, if you have the time, that would be very, very highly appreciated, so we can possibly improve the lectures for years to come and for more students to come. So with that, I think I'll wrap things up. Thank you for paying attention. Thank you for tuning in. I hope this was useful, and I hope you all revise well, and everyone stays safe, and I hope you all pass your anatomy exams when you have to do them. So thank you, and have a nice day.